think we'll make a start as it's nearly 2:05. Thank you very much for joining, and great to see so many colleagues from councils join us from this webinar, especially when you'll be managing so much other stuff in your roles at the minute. So I hope everyone's doing well. Today's webinar really is an opportunity to find out more about the rapid care technology deployment tool that we've developed at Pace over the last few weeks. I won't go into too much detail now about that, but the tool is very much intended to support those of you who are looking at how technology can support individuals as well as those delivering care, particularly during these times. So my name's Abby Vella, and I work at the Local Government Association in our Care and Health Improvement Programme in our digital team. And I'm joined today virtually with colleagues from ReThink, who we've been working together with over the past 6 months or so on a programme of work to support councils with their care technology approaches. So from ReThink, we have Claire Morris and Irene Carson with us. And I think many of those on the call today will have spoken to either of those or both of them in the past few months. And if you've not, there's a good chance that one of your colleagues will have. I'm also joined by colleagues from councils who will soon be sharing some of their local care technology work with you. Colleagues will introduce themselves when they start presenting, but we're really pleased to have Dave Harris and Scott Smith from Kent, Sara Douglas and Catherine McShane from Durham, and Chris Jones from West Essex with us. And finally, last but not least, Caroline, who will be driving the slides and helping with all things logistical for today's webinar. Can you move to the next slide, please, Caroline? Okay. Hopefully you can see the slides in front of you on the screen and the agenda that we'll be working to for the next hour and a half or so. In a few minutes, I'll pass over to Claire, who will introduce and talk us through the rapid care technology deployment tool, which hopefully you've all seen, to give a bit more information about where that came from and how you can use it to support your work locally. We'll then spend some time hearing from Kent, Durham and West Essex about care technology approaches that they have taken during the pandemic. Some of those will be new approaches, and some of them will already have been underway before COVID-19, but may have had some refocusing or shifting in light of the shift in circumstances. Finally, we'd like to open up some discussion about what future support in this area, but also digital innovation more broadly, could look like from a local government association point of view. And it's really an opportunity for you to put forward some asks and shape some of our thinking about next steps. And then we'll close at 3:30. Great. Next slide, please, Caroline. Okay, so logistics and ground rules. There are a lot of people on the webinar, and if anyone's internet connection is anything like mine, then it's temperamental at best. So to try and avoid some disruption and interference, if you can keep yourselves on mute, please, and keep your videos off unless you're speaking, that would really help. We also want this to be as interactive as possible, so we want to use the chat function as much as possible throughout this webinar. So if you've got any questions, please put them in there and we'll pick them up. We'll try to get through as many questions as possible throughout the webinar, but we are recording this and we'll send it out afterwards. And if we don't get to your question, we will follow up with it after the session as well. When you're speaking, please give your name and your role in your organisation. And finally, we'd really like this to be a safe space for people to speak freely. So Chatham House rules would be great as well. Thank you. Next slide, please, Caroline. So I touched upon the purpose of the session at the start of the webinar, so I won't go into too much detail other than give some brief context and background. We've all seen the role that digital and technology can and is playing to support us all through this pandemic in our personal and our work lives, if there is a distinction between the two now. We know that councils have been considering or developing care technology approaches locally, and whilst this was happening in many places before COVID, inevitably a lot of this activity has accelerated at pace and at scale. And in response to that, we wanted to provide some support and assistance to councils to help with some of the common challenges that are being come up against as part of that. I'm going to pass on to Claire in a moment to go through the tool that we've developed in collaboration with councils over the last few weeks, but thought it'd be helpful first just to clarify what we mean and what we're referring to when we talk about care technology. So we've been working with councils for the past 6 months, or so, about care technology in particular, and we learned pretty quickly that the language in this area can often be a bit confused, and people often use the same terms but can mean different things. So we are consciously moving towards using care technology in its broadest term to cover the complexity and blurred lines between the likes of telecare, telehealth, assistive technology, consumer technology, smart devices, and there'll be other terms that you'll use locally as well. Fundamentally, the common denominator for all of these terms is, a role that technology is playing to support independent living and good quality life. So that's the term that we'll be using for the webinar and what we mean when we say care technology. I hope that's helpful and gives a sense of what to expect for the next hour and a half or so. And on that note, I'll pass on to Claire to talk us through the care tech tool and how to use it.
Lovely, thanks Abby. Good afternoon everybody. My name's Claire Morris. I'm a founding member of ReThink Partners. We're a health and social care transformation consultancy, and we do a lot of work with councils, local authorities, national bodies like the LGA, and we also try and work with the market to some extent, so spreading across the sector so that we know kind of what's going on from a number of different perspectives. As Abby said, we've been working with the LGA for about 6 months. We were just on the verge of launching a resource for local authorities to use to plan their longer term services and strategies around care technology when COVID-19 hit. And Abby and colleagues approached us to see whether there was a gap and a need to do something specific in relation to care technology and how it could and was being used in response to COVID-19. So that's really the origins of this tool, and we worked very quickly over the last 4 or 5 weeks to produce a tool which is available on the LGA website, and we've spoken to a number of councils, both old friends and new, and undertook a survey to really get underneath and understand what you are all dealing with and the different ways in which you might be thinking about technology to kind of support and use in response to COVID-19 and the challenges. I think just to say that for those of us who work in this area, there are real opportunities, and some of us incredibly passionate about the opportunities to use technology to support the delivery of social care and to support it and to use it to support independence and good health and care outcomes. But it is tricky stuff. There are barriers, and those barriers have not all gone away just because of COVID-19. Things like culture, attitudes, practical issues around governance, risk appetite, procurement, information governance, all of those lovely things which we sort of grapple with on a day-to-day basis. But what we have seen definitely is a lightening and a real kind of appetite to move at pace that's been, and some space and opportunity that's been created by the current circumstances. And really delighted with 3 councils who are talking today to see some of how that opportunity is being maximised on the ground. So the tool that we've developed looks at some of the challenges that specifically adult social care teams are facing in the context of COVID-19. And we've looked at sort of mapping how different technological solutions can and are being used to address some of those challenges. And then following on from that, based on our experience of working with 3 councils over the current period to support them to mobilise new technology in response to COVID, and also based on the conversations we had with other councils, we've developed a pretty rapid sort of framework, a mobilisation guide, which gives you a series of prompts of things that you might want to think about and ways of thinking differently so that you can move at pace, but also know that you're doing something that's going to be safe and effective and cost effective in response to the COVID challenges. Okay, Caroline, next slide, please. So I'm sure these will be familiar to you, but some of the key challenges that we found that are being faced, particularly when you're looking at maintaining service continuity during the COVID-19 outbreak, but also specifically around use of technology. And I'm just going to talk to those really briefly. So at the beginning, I think there was a lot of concern about reduced care capacity, about trying to deliver, maintain services to people who were shielding, who are self-isolating, the challenge of kind of crossing the threshold when that might no longer be desirable, both for workers or for service users. And indeed, I know that you will all have seen people kind of refusing services and refusing care because they are more fearful of the risk of getting the infection than the potential risks of not receiving the care and support that they need. And what we also saw when we spoke to you was a kind of reduction in the offers that you've got. So some things just have to be maintained, but particularly sort of well-being, communication, sort of employment. So a lot of the sort of day care type services are often shut at the moment or are being redeployed and used to do different things and more urgent things. And that's particularly impacting obviously on service users, but there's also the impact on carers and the sort of lack of opportunity for respite and kind of peer support that we would have in normal times. So really simply, we're seeing less care capacity available, but also a diminished range of care and support offers available to people. And within that, I think we definitely saw an appetite and desire to protect the workforce from infection as much as to protect service users, so that we knew that the workforce was still going to be there. Hospital discharge. So my sense is that this has been very variable across the country, and it is partly related to COVID hotspots, but not entirely related to COVID hotspots. I think very much related to the kind of strategy and approach that's been taken within local health and care systems, and the extent to which people were kind of rapidly emptying hospitals to make way for potential surges. And then we're now seeing that some of that capacity need hasn't arisen. So in some places, it's actually strangely quiet at the moment, and that is bringing its own challenges. But we've seen particular services, particularly reablement or enablement services, that are under quite a lot of stress and pressure. And just generally, I think, to be frank, the NHS putting social care colleagues under a lot of pressure to maintain flow, even though we all think it's quite pressured in normal times. We have seen real challenges around COVID-19 hotspots, and in this context, another tool that's talking about particular settings, and I'm thinking particularly of care homes, but also other kind of residential settings where you're starting to see, obviously, localized infection hotspots, and that is also kind of obviously presenting real challenges for service continuity and delivery. And a thread has emerged actually in the last couple of weeks in conversations I've been having about assessment and how we can maintain best interest assessments and other types of assessment during this process, and frankly not leave ourselves with a backlog, but also make sure we're Care Act compliant throughout. Telecare continuity, I think generally has been fairly solid, but again, concerns around availability of workforce, particularly monitoring centres, and obviously the responder element of that being quite a challenge in the current situation. And then as we've moved through, even already, the focus has shifted away from kind of the immediate, how do we keep the show on the road, how do we keep people safe, into how do we start to think about recovery, both of the system, but recovery of individuals within that. So, the long-term impacts on function, on cognitive ability, on mental health and emotional well-being of living in pretty strange circumstances for people who are already obviously vulnerable and in need of help and support. There has been a thread on digital exclusion which has emerged throughout. So to state the obvious, some of the people that we are all working with are in high-risk groups anyway for being digitally excluded. They haven't got the money, or they haven't got the skills, they haven't got access to technology, and so much is going onto a digital footprint. How can we make sure that those people are not even more disadvantaged than they potentially already were? And I've already mentioned the impact on carers. So there are others. We heard quite a lot about PPE throughout, but we sort of drew the line at not getting into the PPE debate. But those were the main challenges that you told us you were facing and that we've seen from our own experience on the ground. So what are people thinking about in terms of digital and care technology solutions to tackle some of these? So as we are today, we have seen some really exciting and quite ambitious use of technology to support video-based service delivery. And that's both using kind of consumer platforms like Skype, Facebook, Zoom, and a number of systems. There's some lovely learning disabilities work going on in Kent, where they are using Zoom to have group sort of day care provision for clients with learning disabilities and keep them connected to their mates. But we're also seeing video-based service delivery potentially for assessment, for consultation, and as you'll go on to hear, in Kent, they are looking at video-based service delivery to deliver virtual care into people's homes, so to minimise the need for hands-on care, and where they are sort of low-level need visits, using technology differently to enable that. People, just to skip on, are also using voice-based solutions, so just normal telephones or other voice-based solutions for that. But I think there is a real benefit, increased benefit from using video, just a much richer and kind of emotional and social connection. We're also seeing people use technology to help people connect with each other and their loved ones and their informal care networks. So how can we use technology to keep the burden away from statutory services, and help people to use the networks that they would normally use in times when actually those networks can't potentially be physically present. We're seeing so telecare. We've seen the telecare providers, obviously at local and some of the bigger national providers, kind of shoring up their offer, but also doing proactive call outs, and so switching what is traditionally quite a responsive emergency type model onto being a much more proactive front foot sort of approach to telecare. And wedded with that, and Chris will go on to talk about some of this in West Sussex, we're seeing different uses of remote monitoring devices, and we've seen a number of authorities really trying to ramp up quite quickly deploying and sending out remote monitoring devices, either connected or not connected to telecare solutions, so that they're achieving scale quite quickly to keep an eye on people and help them know that they are okay. That is then connected into discharge pathways, where we're seeing quite good use of kit and technology being in the hospital and being sent home with people. So changing the kind of normal operating model, so it's not a referral and then an assessment and then a few weeks later something arrives, but actually just saying, have this, take it with you now, it will help keep you safe. And so we're seeing some real pace in terms of how people are getting technology out. And we are obviously seeing much more use of people's own kit, technology, hardware, to use to support some of those solutions. So not, I've got to give you a box or a device that's from the county council, but actually you've already got a phone, you've got a tablet, actually here's some video software, here's how we can connect with you, and here are different apps. We saw less of this, but we did see some people starting to think differently about how they might use apps to help kind of self-care, self-management, to promote well-being, kind of in the mental health and mood space. And I think there is more of that to follow. And I started to get a sense that people were thinking about how they could upskill informal carers, so family members who are shielding with vulnerable adults, so that they are upskilled and better able to step up and deliver care. Okay, Caroline. So that is the sort of first part of the toolkit. So it talks about challenges and it tracks those more directly through to technology solutions. So in very simple terms, if you know you've got an issue with hospital discharge, or you know you've got an issue with the range of service delivery, you can go into the tool, look at the challenge, look at some of the issues that it faces, but then quite quickly go to, well, these are the types and sorts of technology that might be suitable for bringing in quickly to address and tackle some of those challenges. The deployment, so that's the what, if you like, what we're facing and what technology might be able to do. The deployment guide is very much about the how. So how do we make this happen safely and effectively and quickly, so that it doesn't take 18 months for us to move from recognising we have a technology need to actually having a provider and a service in place. How can we do this literally within weeks? There are some overarching messages within the deployment guide, and then I'll just talk through some of the kind of key practical themed headings that we pulled out. So pace is key. I won't even go there. I think the key point within that is that we're trying to use processes, and particularly internal processes, for governance and decision making that are not designed for speed and not designed for pace and not designed for the current circumstances. But as you all will know, there are shortcuts, there are cut-throughs, there are emergency measures, but there are also softer ways of trying to get your organisation to move quickly and respond quickly to enable you to sort of get this thing moving. We've really found that you need to be really clear and specific about what you're trying to achieve, both in the context of COVID, but also specifically which elements of your challenges you're trying to face. Our experience of working with some local authorities is that if it gets too big and too woolly and too strategic, the messages get lost and it slows it down. So focused, targeted kind of papers, arguments, business cases, etc. Leadership is always important, and it yet again it is important here. And we've seen the need for authorities to make sure that you've got really good strategic leadership. You've got someone at that corporate level who is managing the kind of top of the tree conversation, and that includes a passionate elected member if you've got one. You need good leadership, probably at a commissioner and also sort of project level. And then you need those kind of operational leadership on the ground. So you've got to have that leadership line cutting through. One person, one great leader on their own isn't just not going to pull this off. You'll hear that these are not challenges and issues that we've been through before. So to craft a perfect solution is not the way to go at the moment. And you know, there's lots of talk always about agile, but we're seeing people really being agile in how they are just getting things going and then checking and then iterating and moving. And that's absolutely the right solution. And also the context in which we're working is dynamic, I think, as we're all seeing, but the impact and challenges that COVID is presenting is continuing to move. And we need to respond to that. Think People is all about culture. So even in the current climate, you will all know that there are people in your organisation who are deeply passionate about care technology and get it and understand its purpose. And there are those who don't. And so part of the tactics, I guess, about this is weaving your way through and creating a team to make this stuff happen, where you've got the can-dos and the people who believe in and are passionate about this stuff. At the risk of stereotyping, we found that professional staff and social workers are more risk averse and struggle with this more. There are obviously great exceptions, but we found therapists and particularly OTs are great champions for this stuff on the ground. They really seem to get it quite quickly. So just think tactically about kind of who you're using and how that's working. And I guess don't get bogged down in trying to change, or there's no time for sustainable culture change at the moment, but you can't ignore it. Right, next slide, Caroline, please. And so the themes then that the deployment guide actually then delves into in more detail are kind of set out here. I won't go into all of them. They are in the guide on the website. I think just to highlight 2 or 3 which are key. So governance, that is as much about decision making and permissioning, but it's also about making sure the governance wrapper around delivery in the project is really tight and clear, because it will build confidence, and the reporting requirements back up of these rapid deployments are quite quick. They tend to be, so people want to know what's happening because they might have committed quite significant sums of money to doing something differently. And governance is the bit that is the slowest. So start from day one thinking about information governance, thinking about any procurement or commercial risks, thinking about legal issues, thinking about risk appetite and risk issues, and think about the influencing the softer piece of governance, which is how am I going to get this decision made, and what is the path for that decision. That all takes a lot of time, and is really necessary and important, but can feel like it's sort of necessary but not sufficient in terms of getting the thing done. The care providers and partners piece has been really interesting, and we've seen huge variation in the market in terms of the appetite of care providers across supported living, daycare, whole range, their willingness to step up and engage and think about how they might deliver their services kind of virtually. There's some amazing champions out there, and there are some who say no. But think tactically about your communications and engagement, and how you're going to involve them in this if they are mission critical to it. And I guess the last thing is to say we are all having to think differently about benefits tracking, which is always a challenge for care technology deployments in any case. But we've now got the added overlay of demonstrating impact in the context of COVID. So have we kept people safer? Is the workforce more available because we've taken various steps? Are we keeping people safe and well in their own homes? Okay, I'm going to stop there. You can hear I could talk about this for forever, because it's I'm quite passionate about it, and there's lots of learning there. I'm just keeping mindful on time. Irene, are there any key questions that you think need to be tackled at this point?
Yep, just a quick one. I can see that Sarah's responded to Lewis's question, so thanks for that, Sarah. I think, Abby, if you could just respond to Bradley's question about Lottie.
Great. Thanks, Irene. Thanks for your question, Bradley, about Lottie. Yes, we have been engaged with them. So that's the London Office for Technology and Information. We've been engaging with them since we started the work with ReThink about 6 months or so. So this resource is very much intended to complement the work that Lottie has already done in the area. And for those on the call that aren't aware, that the London Office for Technology and Innovation, I'm not on video, so I'll just pop myself on while I'm speaking. The London Office for Technology and Information has done a lot of work with London boroughs predominantly about tracking the benefits of assistive technology. So we can share those when we circulate the slides after this webinar.
Okay. I think, sorry, just looking at the thread that's down there, and I think this is actually quite a nice lead in to the first case study from Kent. A lot of you are flagging the software is there, but it's the hardware that's the issue. And I won't say any more, actually, because I'll hand over to Dave and Scott, because Kent have been doing something really interesting, which is a combined hardware and software solution, which gets over some of those challenges. So a perfect lead in, Dave and Scott, and I'll hand over to you.
Thank you, Claire. Lovely segue. Afternoon, everybody. So yeah, Scott and I will just take you through our experience in Kent. So if you can have the next slide, please. So we've purchased 2,000 devices. We very quickly realised we need to expand these to a wider cohort as possible, because, as Claire has already touched upon, there are so many vulnerable people and people requiring additional social interaction that aren't able to have the thresholds crossed, whether that's in care homes or out in the community. But also we've extended it to the voluntary sector, to preventative services, through our discharge services, through our time-limited enablement services, including older people, physical disability, mental health and learning disability. We've also, through our purchasing teams, so we're able to capture any gaps that are coming through of people reducing their care packages to minimise crossing of thresholds, to unpaid carers, because ultimately we need to mitigate against carer breakdown, especially during COVID-19 and lockdown, where carer support groups aren't possible to be delivered. And most interestingly, recently, the more information that our practitioners and colleagues understand about the offer, best interest assessment. There's an awful lot of care homes that don't enable anyone to cross the threshold at the moment. It's certainly where they've got symptomatic and isolated clients. So we're actually working with our DOLS team to be able to facilitate best interest assessments using the technology. Obviously, we've got to reduce social isolation, as I mentioned. An awful lot of vulnerable clients, including shielded clients that are unable to have people cross their threshold. So we're looking at every avenue that we can utilise the technology for that. And obviously supporting the workforce where they're being socially isolated and self-isolating themselves, where they're becoming symptomatic. So where we're seeing pressure on our providers to continue to deliver as much of the care and support that they're able to, this technology is enabling them to maintain some of that contact, albeit not being hands-on care, but in terms of prompting well-being checks and just maintaining that engagement in terms of continuity of care. I'll leave the lessons learned for Scott on the next slide, but certainly the contracted provider market rollout support is critical to make sure that they're not only just brought on board in terms of the briefing, but that we keep working with them, because they will each individually have issues that arise that are specific to them. But I'll pass you over to Scott in terms of lessons learned.
Thank you, Dave. If you just have the next slide, please. Yeah, so as kind of Claire was alluding to earlier, it's about kind of having that key management and leadership structure that kind of all the way through. And one of the things that we picked up on quite early is that obviously having a dedicated resources for a project manager and commissioning lead as well will help kind of drive that forward. And it needs that kind of two-pronged approach, especially because the commissioning lead has those relationships with the providers themselves. And obviously the project manager can then do the actual governance and internal stuff a bit easier as well. So that worked well for us. We've got good links in with the SRO, obviously Dave being SRO, and our corporate director as well. Have been overseeing this, but we've got good links in with them and keep maintaining good communication. It's great for kind of clearing decisions or any issues that we've got, and that's helped us kind of maintain the progress of the project as well. It was better for us to get legal advisors in sort of at the outset to help us with kind of contract negotiations and things like that, as well as the data protection issues. So we need to seek legal advice because this was a new initiative for everyone. So there was nervousness around what this initiative was and the data we were sharing with an unknown provider almost. So they definitely helped us in bottoming that out so we could move the project forward. And I think, again, something Claire alluded to earlier was about obviously the culture change piece is hard to do in such a short space of time, and it does take a period of kind of several months and even a year or so to kind of really bed that in. So what we try to do is kind of document everything we've been going through and circulating it and meeting with the individual teams and really trying to bed it in with the senior management team to start with, and then through and down to those kind of actual practitioners and social workers as well. So it's been challenging, not on occasions, but everyone's buying into it. Everyone's really trying their hardest and can see the real benefit that this is generating for not only the providers themselves and the practitioners to stay in contact with people, but also the main thought is obviously with the clients and our service users. And I think the biggest thing was just don't underestimate the data protection issue is our biggest thing and lesson learned, because it just takes us a lot of time to get that bottomed out and get that right. So don't underestimate it if you do something similar. That was it I think, from us, and I've just got our contact details on the next slide, but I don't know if anyone's got any questions or answers for us.
Before we go into the Q&A, do you think, Dave or Scott, could you just describe the device a bit better in terms of what the technology is you're deploying and what it can do?
Yeah, no, of course. I mean, in its simplest, it's a one-touch FaceTime equivalent. So the individual receives a 10-inch tablet. It's locked to the functionality of giving and receiving calls. It's also secure because only those individuals that they've chosen and been selected to be part of those calls will be on the tablet. So they know that if there is a call received via the device, it's someone that's already been identified and they've agreed and consented to being on there. So it's as simple to set up. We've got the portal where we can monitor duration of calls and time of call, and we can also see if someone's missed a call, so we can check on those. But it's really enabling friends, family, practitioners to be able to liaise via video during this time of crisis. But it's in its simplest essence, it's a one-touch FaceTime equivalent video call.
The great thing about it is that it's completely locked down to who kind of we want to have access to it, or who the client wants access to it. So it's not the same as kind of the FaceTime or the Zooms and things like that, where anyone could access that telephone number. It's on a whitelist, which means only certain people who have the permission to do that can access it, which gives that kind of reassurance for clients and families as well.
I guess, sorry, just picking up the questions about connectivity. Sorry, I feel like I'm prompting you now, but it's got a SIM in it, hasn't it? So that's one of the ways you've tried to overcome the connectivity issues.
The tablet has a built-in SIM. It's a roaming SIM. So one of the issues with a digital by default solution is an awful lot of people do not have broadband or Wi-Fi. So this circumvents that and mitigates that risk. We've only had one occasion where a client was living so rurally there wasn't any connection at all, but other avenues are being looked at in terms of broadband or connectivity in that case. But for the vast majority, having the roaming SIM is certainly an enabling tool rather than relying on broadband. I noticed one of the questions was how Kent have funded this. Well, Kent as the council obviously offset at the earliest possible time some central budget allocation in relation to a COVID response, and it was signed off and approved when we weighed up the benefits, initial benefits and theoretical benefits of introducing this technology. So that's where it was funded for.
Just going back on to is this a free software solution for all? So for anyone who, obviously the cost of the actual product itself and the SIM card and everything else that comes with it is obviously funded by KCC, but any kind of friends or family that want to access the portal, as long as they've got an internet connection and a web browser, and obviously to be able to do the video calls, it'd be a camera of some description on that device, then they can actually do that and get through, and it's free of charge. All they need is a login. And just another question from Lewis on the procurement mechanism. We went through G-Cloud framework, which is an IT framework, and it allows you to kind of go through some different scenarios and put in some criteria, etc. And then it comes out with the providers that you can contact, etc. So our way through to our procurement route was for a government framework.
Yeah, I'm just looking at the question there from Sheldrake that have social workers been using it for assessments? That is the plan. It's still early days. We're in the rollout. We're still gaining traction on that, but things are happening so quickly that, as Scott mentioned, we're making iterations through lessons learned. As more and more people are understanding what the technology is, people are thinking really laterally, and we're now rolling that out so assessments can take place. So certainly in the coming weeks, we'll be able to have a benefit analysis of how that's working in practice.
In terms of who's monitoring the portal activity, so if device runs low on battery or has not been used for some time, an alcove and the portal access kind of has a reminder that pops up on the screen. So anyone who has access to that kind of side of the system, whether it be friends, family, or alcove themselves, can actually call the individual just to remind them to either plug it in, or they can send a reminder, actually like a a written one through to the device saying, can you remember to plug your device in, etc. We're part of our data protection stuff. We're obviously not monitoring kind of what people or what the conversations are with people, but we can see kind of number of calls that are going to care providers or friends or family, just so we can kind of do some analysis about how the device is being used.
Yeah, and I know this has been covered in the chat, but Geraldine asked the question, which is the company that supported us to develop the software. We're working with Alcove and ReThink.
Yeah. Just Jude as well. I think where there issues with training of staff to use it. No, everyone really bought into it. We did kind of initial briefing session at the start just to kind of introduce what the software is and what the products are. And then Dave and Alcove have been kind of running those training sessions, and it's been really kind of challenging in terms of how people want to use the technology and really trying to understand how it could be used in their kind of setting and stuff. So yeah, it's been really positive from what we've seen.
Again, Sheldrake's asked, is there an intention to build on the tablets deployed? Absolutely. I mean, without going into details, Kent are looking at its large digital tech offer anyway, and what that contract will form. So although COVID has given us the opportunity to develop this technology to support the crisis, we're using the benefit analysis to feed into what that longer term solution may be, but it's too early to say at the moment.
Sorry, Debbie asked a question about who's responsible for picking up calls when they're not for checking on the services. So just sort of operating model around it, Scott?
Who's responsible for picking up calls? Yeah, so obviously if anyone misses a call on the device, then it goes through to their portal notification, so they actually get reminded where they've actually missed it, and they can obviously then go back and actually answer the calls. What we've done with our tiles is we've kind of got Alcove, who's got a technical support for any issues with the device itself. We've also got the concierge or the help at home service, which means that if the care provider or the practitioner or anything like that isn't available, they can actually contact Alcove, who would then kind of help support that service. It's 9 to 5, Monday to Friday, but it's just like an extra support network there for them if they need that kind of urgent support. And then obviously the practitioner or the care provider can then contact the client once they're in a position to do so, because they probably have multiple clients that they're trying to get round to at once. So.
I never wanted to play a game where I didn't score the real money.
Bradley's asked a question about, have we spoken to Essex? Yeah, we do liaise with Essex and other local authorities in terms of their digital and tech offers. So yeah.
Yeah. Shall I just talk about? Sorry, Bradley's asked about cost, and the cost of the hardware is £300 a month. Sorry, it was £300 up front. There are additional costs because we're deploying them with SIMs at the moment, and there's a monthly license fee of £20 to Alcove. But we're using it as part of hospital discharge. Hospital bed day costs £600. So reduce the length of stay by a day. You've recouped your cost. Obviously, you need to kind of work out cashable how you get that kind of back in. And as Dave has already said, it was funded from emergency reserve. But in normal time, the Alcove kit more than pays for itself very quickly in terms of cashable reduction in care costs, particularly when it's deployed with the other Alcove devices. That's what a tablet costs, that's what an iPad costs, but you get much more with the Alcove setup. And I think we found already just the kind of positive impact that it's having on people's lives is really profound. To be honest, particularly the tiles that connect people to friends and family at the moment, people are finding that hugely valuable. And these are people who haven't got any tech and wouldn't be able to be contacting people. We had in Kent last week a woman who hadn't been in touch with a school friend. She was normally in routine touch with an old school friend. She hadn't been able to see her for weeks because of COVID. Got a video care phone. They sat and looked through old school photos together for an evening. Kind of precious stuff, really. And we are it's starting to be looked at to support people who are elderly and bereaved as a result of COVID. That's a growing kind of use case and concern as well. Sorry for coming in. I just thought I'd better talk about the costs.
There was a few more questions there.
Yeah.
There's one about if it's been used. This is from Lewis Sheldrake. So if this has been purely used in Kent for social isolation, or are you using the help function on the tablet integrated with dependent style alarm buttons to prompt a response service?
I mean, ultimately, as we already covered, we're using it for a myriad of reasons. Quite clearly, the predominant benefit is going to be during lockdown, additional social interaction with friends, family, and enabling some remote virtual continuity of care for existing care packages where they've been reduced because of crossing thresholds. However, yes, of course, on a case-by-case basis, if that could be looked at as a possibility. But we're also using it, as I mentioned before, about doing assessments as well. So assessments and reviews. It's too early to say how effective that's going to be. But clearly, there's the same limiting factor that a lot of our practitioners are unable to cross thresholds where there are care homes that are completely locked down at the moment due to symptomatic clients or people self-isolating. So this will potentially enable them to be able to continue doing those assessments and maintain contact.
And I think Scott and Dave, there's a couple other sort of similar requests around being able to share some of the making the case for this, so the business case, the cost benefit analysis. Is that something that you might be able to share with others?
I think as we go forward, I mean, we're early days yet. We're at weeks into the rollout. So as we're looking at the benefits analysis, I'm sure we would be able to share some of that information as we come through it, but it's too early at the moment as we speak today to be able to share that. But as we go forward, then yeah, there's absolutely that possibility.
There are some of the decision-making documents, Dave, aren't there, that are in the public domain if people. That's free rather than post. But
sure, yeah, absolutely, yeah.
I'll see if I can find a link to that and post it in the chat.
I've got it. I sent it the other day to someone.
Can we move on to
Sara?
Yes. So next slide, please, Caroline. Catherine needs a video on as well. So I'm Sarah Douglas. I work for Durham County Council. I'm part of an integrated commissioning team, and I'm the lead commissioner for Health Call Digital Care Home. And I work very closely with Catherine, who works for the Trust, which is who we've commissioned the work from. I'll let Catherine introduce herself formally.
Thank you. I'm Catherine McShane. I'm a dietitian by background and have been involved in digital health now since about 2012. And currently project managing the implementation of the digital care home service within County Durham.
Right, Caroline, can you see, we've done a little, if you can do the link for the animation, Caroline, if that'll work, please.
Health Call Digital Care Home is a unique solution, enabling care home staff to share information about their residents with health professionals. Designed to replace old referral methods, it's safe, secure and compliant with NHS data standards. Trained care home staff concerned about the health of a resident can quickly make referrals, and it can also be used to monitor the health of residents through the regular submission of observations, recording what is normal for them. Additional information using the S-bar tool can also be included. With every submission, a News 2 score is generated, connecting all core primary care and community clinical record systems. This is passed to the relevant clinical team, and the electronic patient record is also updated, ready for a clinician to plan appropriate action. The care home also receives confirmation that the referral was received, with any initial clinical care advice. Where regular observations are being recorded, signs of early deterioration are picked up and responded to by community health services. Health Call Digital Care Home, enhancing the connection between care home staff and residents and our NHS.
Thank you. Next slide, please. So that animation just helps people understand what our system does. We've talked about this at lots of different events, but we felt we needed a really good way to explain it to people who weren't familiar with the system. So as you can see, it's basically an app or a system that can be accessed through a web page that enables electronic referrals to be made and for remote monitoring by health professionals in the community and primary care. Also enables, as well as referring when there's issues, that they can do baseline observations submitted to our health colleagues. And then, like the animation said, we're tracking, looking to see where there's signs of deterioration. In terms of what we give to the care homes, we give them all a pack. So they get tablet, blood pressure monitor, pulse oximeter, thermometer, and that's the kit that they need to be able to use Health Call. And of course, they receive training on both doing the observations, which they signed off on as competent, and support with using the app and the web page. So at the minute, that's what Health Call consists of. But we were also pre-COVID already thinking about how we were going to include wound care. So where we could track progress of wounds, and the care home will be able to submit photos. And this information all links through to the electronic patient record, so that's really beneficial for our colleagues in health. And then video consultation is the one that's really come to the forefront with COVID, and some of our care homes struggle with Accurix and MS Teams. And also we need video consultation that enables MDTs, so Health Call is going to be able to do that, and that should come online early next month. And then the other element, which again we were planning for pre-COVID, was where the care home staff will be able to submit weights for residents who were known to our dietetic service. And then when the MUST score is generated, any issues will trigger a response from our dietetic service. So what we did, I think really the main thing to highlight is that it wasn't a case of we've got some tech, how can we use it? It really did start with a problem. So working with the care home and the trust and the GP Federation, it was identifying how could we make things better for all parties involved. And it was partnership working throughout. The care homes truly were engaged in the process, so the development of how it would work, and then ongoing improvements to the system. So we're now at 92 older people care homes, with a couple to mop up by the end of this month, and now live in 2 extra care establishments. So why we did it? It was easy for the care homes. They were spending too much time on the phone, and time on the phone means less time with residents. So obviously that's something we wanted to overcome. But also we wanted to receive good quality referrals from the care homes, and that meant that it would be a more efficient system for all involved. So the nursing staff would have better information to prioritise and plan their work. Of course, we were looking to reduce unnecessary admissions to hospital, and we know that Health Call Digital Care Home has done that and is helping with identifying the signs of deterioration. But most importantly, it does mean that our residents and service users are receiving improved care. So I've talked about some of the people we're involved with already, but the company who is responsible for the software is Health Call Solutions, and Catherine can talk a little bit more about them when she comes onto her slide. And then in terms of COVID, how it's changed, well, we did originally have a plan to get everything done in 2 years, but we had to obviously expedite that, and we managed to get it done in 14 months, which is quite amazing that Catherine and her team managed to do that. And extra care has started, and we weren't anticipating to do that as quickly. The other good thing is that obviously it reduces footfall in our older people care homes and the extra care establishment at a time when they don't really want people crossing the threshold, because of that ability to do remote monitoring of the residents, and they're still able to access that remote health support that they really need. We also added, as part of our, obviously, we've got lots of communications going out to care homes, and we built our process for COVID-19 resident testing, where they would make referrals through Health Call Digital Care Home, again, a system that they're already familiar with, and this would be easier for them. The other thing to just add really was that there's less staff. We all know there's high rates of staff absence at the minute. So what we don't want is for care staff to be wasting time on the phone, or doing things that we know can be done in a much more efficient way. So Health Call Digital Care Home has definitely contributed to more efficient work within the care homes. And I think I'll hand over to Catherine now. So next slide, please, Caroline.
Thanks, Sarah. So looking at some of our key challenges and the lessons learned that we've had from this, some obviously we were experiencing pre-COVID, and during COVID we've got slightly different ones, but some same things that have been a similar kind of like theme throughout. I think things like the IT infrastructure in care homes has been a problem, and I've been working in this area for like the past 8 years, and it's been an issue. It is improving, and I think COVID is obviously driving a lot of that at the moment. But you go from care homes that have got full electronic care plans and they're using tablets already to record some observations, to homes that have got 1 or 2 computers that limited staff have got access to. So as Sarah mentioned, we have provided all care homes with tablets to enable them to be able to do this. But I think one of the challenges with COVID is that we're potentially bombarding care homes with some technology around that, and I think part of it is around engaging with, or just linking in with the care homes and the bigger companies around what they want, because ultimately we're giving them assets that they then potentially need to maintain and keep, particularly if it's things that have got contracts or SIM cards and things that that we potentially are burdening them for future use with that. One thing I think we've also highlighted is things like digital skills of care staff. We had assumptions, I guess, that the majority of people know how to use smartphones and that they use them regularly, and a lot of people do. But equally, there are some people that have never touched a smartphone or device in their life and are quite anxious around using some of the technology, more so using those than they are in taking a blood pressure or O2 sat, for instance. They're far more comfortable with that than actually using some of the technology. We have engaged all like care home staff right from the beginning. So when we were developing this, care home staff were involved in that process around the way the questions were worded, what the forms looked like, how it worked, so that at least we've tried to make it as simple as possible for staff, so that when they are using it, it's intuitive and it's not creating a lot of burden or anxiety for them. With that, things as been mentioned prior to this is around the connectivity issues, which has become more apparent during COVID, not just because of this, but because there's far more of a drive to improve the digital connectivity within care homes. And even if it's for allowing residents to being able to connect with their relatives, that if you've got broadband that's fine in the kind of like reception area, but up in somebody's bedroom, it's not particularly great, so they can't use the devices, then it's looking at how that can be, and that's been a challenge for us with that. As mentioned, we've had care homes refusing a sentry with COVID, and actually we've probably got more of a challenge for that now. If homes have got no COVID in them, they're not allowing anybody across the threshold. And for that, prior to this, the local authority and Sarah's team were very keen on ensuring the care homes were aware that we were part of the essential services, that by letting us in, providing the training, providing the equipment, would then longer term enable reduced footfalls through to the home and enable their better connection with the health services. But once we've got homes that have got no COVID in them, we're struggling with gaining entry now for that. So we have looked at other ways of doing it. So we've created videos around how to use the app, any common problems. We're using some of the NHS Education England videos around some of the monitoring of BP and how to take blood pressure and things like that. We do training over the phone, we do it over video conference, so we've had to think quite differently about how we're providing that side of things. Providing kit has been a real challenge at the moment. So down to when this first happened, tablets were very difficult to come by. So to enable the homes to actually provide the information, we cannot get thermometers at the moment. Pulse oximeters are in short supply. Thermometer covers are proving to be difficult to get hold of. So trying to then provide the homes, or for the homes to provide themselves even with the ability to provide these readings, is proving to be a bit of a challenge with that. I think COVID has obviously been horrific, but I think from a positive point of view, it really has driven the digital agenda. I think it's also meant there's a lot of barriers that have been removed in terms of a lot of the bureaucracy has reduced. It's still there, but things are being approved or being signed off a lot quicker than they've ever used to being. So things like getting the videos made was a lot easier than it has been in the past around trying to get things moved. Quickly about the lessons learned, I think really the technology is probably one of the easiest side of it. The bits around it are the harder bits to work out. So engaging with all the stakeholders, so where that information goes, who's going to do what with it, how that's then going to get transferred to the people that need to know about it. I think at the moment we've got challenges where it's being deployed in other areas regionally that because everything's changing on a daily basis, trying to work those pathways out has been proven to be quite difficult, particularly where you've got staff that have been deployed elsewhere that would normally have been, so like your community nursing staff that potentially have been deployed elsewhere, or the admin that have been deployed elsewhere. So just trying to work out what those pathways are has proven to be a bit more of a challenge. But once you've got those bits, and it's just making sure that you have got all the key people involved with that side of things. And it's around providing that ongoing support to the care homes. There's absolutely no point just giving people technology. It only works if you provide that support and ongoing support and support that behaviour change of it. If you just put something in, they won't use it, and as it is for the rest of us, it'll just sit there and won't get used, and it'll not work. The care homes have been involved in it right from the start, as I mentioned, but they're also feeding into us and having ideas about how it can change, what improvements can be made for it, what other uses it has from it. And I think it's just recognising some of those, that they are providing really good information and good ideas that we can then potentially use and just improve what we're doing with that at the time. I think, Sarah, is there anything else that you?
No, I think that's the main thing. I see a question from Abby about feedback from residents about impact. Now, we did engage with our local health watch to seek feedback from both the care home staff and residents, but it was challenging, wasn't it, Catherine?
Yeah.
For them to. It was quite early in the project, and so what we decided was that we would wait till we had more care homes implemented, and we were meant to be starting with the Health Watch consultation round about now. But obviously with COVID, all of that's had to be suspended. But we have had feedback from care home staff about how the residents feel, and Catherine's probably better able to talk about that side than I am.
Yeah, I think it can be quite difficult, depending on the care home. It's been quite difficult sometimes to get feedback from the residents. One at the initial care home that we piloted this in, their residents are probably fitter than a lot of care home residents, and we've gone and spoken to them and actually felt that they were being better cared for. That normally they would say they don't feel very well. A member of the team would say, "Oh, go and call the GP, go and call the district nurse," and they wouldn't know what was happening until somebody actually came and visited them. Whereas with this, it kind of starts that process off that their readings are taken, their observations are taken. Often that's done in the room with them, so they can see that it's been put into the app. So they just feel as though that they're kind of like being looked after a bit sooner than that. And from a relative's point of view as well, we've had feedback around the fact that they feel more reassured that they've got healthcare that are looking after their loved one. But even if it is like they're providing information remotely, but somebody's looking at that and looking at the priority of that person.
So Neil's asked there, Catherine, about whether health call service is still provided by local NHS providers. So obviously, I'll let you describe Health Call Solutions, which is NHS. It is NHS.
It is, yeah. So Health Call is an NHS organisation. It's owned by 7 of the North East North Cumbria NHS trusts, so they're all shareholders with it. And regionally, we've got a regional license to be able to use this across the North East and North Cumbria area, which means that we've now got 3 or 4 other organisations within that area that are starting to take on the digital, or start to implement the digital care home side of things. So Health Call is an NHS company. We partner with, or our supplier for the software is a company called In Healthcare, and they're based in Harrogate, so it's a UK-based IT software company. But the idea behind it is that we exploit, I guess, if you like, the clinicians around that, and that anything that is developed is then available regionally, rather than each organisation having to do their own thing for that. But equally, it can be used nationally as well.
Great. Sarah and Catherine, thank you. So I'm just going to pass over to Chris now, because we're just a bit over time. But if people are happy to keep questions in the chat box, I'm sure Sarah and Catherine will respond on the chat bar. Chris.
Brilliant. Hi, everyone. Yeah, next slide, please. So I'm Chris Jones. I work in adult social care in service development and commissioning at West Sussex County Council. Our story is a little bit different to the 2 that have gone before. Essentially, West Sussex has been adopted as everywhere has, really, strengths-based practice approach over the last 18 months. Our care technology approach very much fits within that. We're in a very slightly unusual situation, probably very unusual situation, in that so we have joint commissioning across the council and the CCG via a pooled budget for our care technology. And in terms of where we are with our commissioning, we've actually only awarded a new contract in February. So we actually went live with a new care technology service 2 days ago, and so have been mobilising that service throughout this COVID period. And that's been a very interesting experience, as you can imagine. The previous provider had been in place for 10 years, and very early on in the process of mobilisation, COVID hit, and so we were very quickly asked to look at hospital discharge as a key area, where we were asked to look at whether care technology could have an impact and support fast hospital discharge, with the very significant increases that were expected in terms of hospital discharge over the peak period. So we essentially were asked to kind of deliver on that and look at how we could deploy some technology to support that process. In terms of the challenges that we had, obviously there was this kind of tightrope walking, as we described it, of trying to support an existing provider who literally had 7 weeks left of their contract. Were having challenges around access to PPE, challenges around their staffing, and look at how we could deliver on kind of fast hospital discharge support, at the same time mobilising a new contract, and all the involved with that with our new provider, and so the challenge really was trying not to lean too far or focus too much on one at the detriment of the other, and of course all of the other inevitable challenges that we had around time, capacity, things like that that we kind of listed here, just in terms of how we could deliver on both of those things at once. I think the challenge around the data that we had available was a considerable one in terms of putting together business cases for additional investment. Also, though, around the fact that we had a whole range of stakeholders and, of course, 2 tech providers that we were working with. And so, as I've described here, I think headspace to actually really consider the options in a robust way, not making any kind of knee-jerk reactions was really kind of key to that. So in terms of what we did, the approach we took, the range of options we looked at, the options we looked at actually mirrors those that Claire spoke about earlier in terms of those available around hospital discharge during this period. So kind of video-based care delivery, around the use of kind of telecare services to check in and monitor with people, the use of remote monitoring devices, and then also, of course, the issuing of equipment directly from the hospital. So the kind of telecare in a bag type approach, which of course reduces the infection risk from home-based installation, and has a whole range of kind of advantages. And of course, that could be devices like community alarms, falls detectors, etc. However, given the very particular contractual position we found ourselves in, as well as the other challenges that were highlighted, we actually looked very quickly at scaling up an existing initiative that was in place. It was a kind of a small same-day discharge option that the existing provider was already offering to 2 of the 4 acute hospitals in West Sussex. And essentially it was a telecare in a bag project where hospital staff could issue a mobile handset with an emergency button that could be linked to an emergency monitoring centre, and they were doing that from 2 hospitals. And essentially, we gained agreement very quickly to scale that up across all 4 acute trusts, and to ramp up the number of devices that were available for those trusts. And so essentially we were able, because we took that approach, to deploy within kind of 10 working days. So by the 14th of April, that was in place. And essentially what happened is the existing provider delivered that for 5 weeks. And then there had been agreement that the new provider would take that on in the same manner from Tuesday of this week, in fact. And so in terms of the impact, it wasn't actually what we expected. I know this is an experience that's borne out in other places across the country. So we're expecting very high numbers of hospital discharges. That isn't what happened. So we'd prepared for that. But in fact, the way that the 4 acute hospitals were operating changed kind of radically, really, over the course of a month. We have very different patterns of activity. Patients were being discharged, but with quite a high level of dependence and acuity. And as a consequence, a higher number than anticipated were actually being discharged, not home with an intervention like care technology, but rather to community hospitals and care homes prior to a return home. So yeah, not what had been expected at all. However, there were a number of real positive byproducts. The engagement that we had across the system. So it certainly either developed new relationships or solidified them in partnership working across health and social care, particularly with our acute trust colleagues. And it certainly gave increased exposure to care technology, I think, for some who had not had an awareness of it. And in terms of this particular kind of scaling up project, actually there's a commitment to continue that, and there's a desire, certainly from the acute trust, that should continue ongoing, and particularly if we see additional peaks coming with the pandemic. And it's certainly supported perhaps a smoother transition than we might have expected between the 2 providers, which happened, of course, this week. So finally, for me, in terms of the learning, and it's that expression agile, it was really that we were able to take an agile, flexible approach. We were able to work as partners with both providers, and to not be taking the letter of the contract approach, but looking at support each other through the situation. And then what we found with our partners across health and social care is very much been developing a shared vision and understanding of what care technology can achieve, and also really getting a shared understanding of the benefits, agreement and willingness to kind of really, in a robust way, track the benefits and the impact, and to look at how we can go forward and innovate more in the future. And that's it from me.
We got any questions for Chris? And thank you for the feedback, John.
I've just seen a question from Sheldrake regarding whether the providers were both external. Yes, they were both external.
Oh, another one from Philippa there. Are there ongoing costs for the telecare in the bag in the short term?
Yeah, so the model that we have is a new model for us. We previously just had a short-term telecare model where individuals would then look to become private payers at the end of a short-term provision. We actually now have a mixed model where we have short-term and longer-term provision. So some individuals will potentially become private payers at the end of that period, and others would actually have assessment to determine if they were eligible for longer-term funding through the council and CCG.
Are you able to say what kit you're using, Chris?
Yeah, so we're using the Ownthone product. That was the kit that we already utilising, that we could get our hands on, increase numbers quickly.
I don't know if you can see the questions, Chris. Claire had one. Do you think COVID has distracted you from your long-term aim, or do you think that you will have made faster progress in the end?
I think certainly faster progress in the end. I think the relationships that have been built will help us to do that. I mean, certainly the new contract, the whole intention of it was really focused around innovation and the opportunities. And it's exciting hearing the things from colleagues in Kent and Durham that they've been doing. Obviously, there has been that temporary, I guess, distraction through COVID, and again, essentially a telecare in a bag option is certainly probably not what we considered we'd be spending our time looking at. A whole range of
a couple of the questions about what's in the bag. I think you said it was a mobile handset, an emergency button. There's another question about age and stage of the cohort. I assume that is.
Yeah, I mean, predominantly it is. So we have 850,000 people in West Sussex. We've got 170,000 people over 65. I think the cohort that we are anticipating in particular were the kind of 80 pluses. And so yeah, that's very much the kind of the kit that was being looked at as appropriate for that group. Things turned out a little bit different as I've described, and the age profile was a little bit different. But no, it's essentially what we deployed.
I think we're going to have to wrap up, Christy, but we'll make sure Lewis and Geraldine and John will respond to those other questions as well. Thank you.
Brilliant. Thanks, everyone.
Back to you, Abby.
Great, thanks, Irene, and thanks to colleagues from councils who just took us through the last half an hour or so. We've got about 10 minutes left, and we will close on time. Let me put my video back on. But we did just want to spend a few minutes talking about next steps for this particular care technology piece of work, but also broader LGA digital support. In terms of the care technology tool, this is very much intended to be a starting point upon which to build with local examples and case studies from across the sector. We have just published the first case study on virtual care, which covers approaches that Essex, Kent and Suffolk have taken, and colleagues from Kent have spoken about some of that work today. We'll share the link when we circulate the slides, but it's also available through the landing page of the care technology deployment tool. And over the next few weeks, we'll be adding to this resource with case studies around hospital discharge, but also care homes. So a couple of asks really to those who are with us on the call. The first is if you'd like to contribute some of your local work to any of these case studies, and we'd love to hear from you. Our digital team contact email address is at the bottom of the slide, so please get in contact with us if you'd like to share some of your local approaches. The second thing is if there are additional themes you'd like to see care technology case studies on, please do let us know. We have had a few requests, and Lewis Sheldrake, who's helpfully added some questions in the chat box today, mentioned around remote assessments in social care. A couple of councils have asked us similar questions, but we're not really getting a sense yet or seeing any examples of where this is happening in practice for us to share some of that learning. So if there's anyone on the call that can share some of their local experience in this area, particularly around remote social care assessments, then we'd be really keen to hear from that. But there might also be other themes too that you'd like to see some resources and case studies on. So if there are, please let us know, either through using the chat function now, or if things come to you later, then let us know via email. We'd also really welcome views on further support that we could offer you from a digital innovation sense more broadly. So whether that be funding for specific digital projects or hands-on delivery support, guidance on particular areas, and we're hearing a couple of councils mention some guidance around how innovation in digital can really inform commission in practice. We'd really welcome some input into some of the thinking for the shape of our work programme, and nothing really is off the table at this stage. We probably haven't got a lot of time to get into a really in-depth discussion about your needs at this stage, but perhaps we could schedule a follow-up webinar to talk about in a little bit more detail. I guess it'd just be helpful to use a couple of minutes before we close to hear any suggestions that you might have at this stage for what we could take forward around digital and innovation and our work to support you with that. And if you've got any additional questions, then please use the time now to ask those. Okay, I see a question from Mark, or a comment from Mark about Tech Viennese effectively assist with DOLS assessments in care homes. Sarah, I don't know if you've come across any of this in your work in the Northeast in Durham, but otherwise then we can definitely look at what we know from across the sector and try and provide some examples to you, Mark.
Well, because obviously local colleagues in the council know that we've got Health Call, they've approached us to see, you know, what options they've got for things like DOLS, best interest assessments, all of that kind of stuff. So they were keen to use MS Teams, but some of the providers struggle with it, I'll be honest. I know we're doing lots to support them both in County Durham and, you know, in the region and nationally, but the reality is that some do struggle. So one of the actions that Catherine and I just discussed last week was, could we extend this to also be for local authority staff as well? So obviously there's some discussions I would need to have with colleagues in our adult care service about that, but it's the start of an idea which I think would have some legs, and it would be great to have that social care element included as well. Because although the care homes, obviously the council has an interest in how they deliver their services and we're keen to support them, and for us to be able to take advantage of the tech as well for a social care perspective would be fantastic.
Great, thanks, Sarah. And a few other comments coming in about remote assessments. So yeah, we've got that noted, and we'll have a conversation about and then in a bit more detail and give some more thinking to that. And then this is mentioned pre-COVID, but business cases, cost benefits analysis feels like there's a big ask from the sector about some support with developing cost benefit analysis and making the case well and articulating business needs when it comes to care technology. So that's really helpful. Neil and Philip on funding. Yeah, which we'd agree with, and we can raise some of these with our national partners as well. And thank you, Bradley. We're aware of the switch over, and we're also in conversations with national bodies about supporting the sector with this switch over, switch from analogue to digital services. Please keep your views, questions and comments coming through to us, and as we switch the webinar off, then please use our contact email address. If it's helpful, then we're happy to schedule a follow-up webinar, possibly to talk about our shape of our support offer to you moving forward. But this has given us some helpful hints and tips to start that process. I think that's everything for now, and we'll give you 4 minutes of your time back. But just wanted to say a really big thank you to those who have joined wherever you are across the country, to our speakers and presenters today. And to other LGA colleagues who facilitated the webinar. We look forward to speaking to you in follow-up conversations after, but we'll share the slides and circulate after today. Thank you, everyone.